All right, welcome back. I'll give everybody a few minutes to find your seat so that we can start the next section of this morning's plenary session. Although I really hate to interrupt the networking because that's really the primary purpose of these meetings. It's making those relationships that can kind of move things forward and in very positive ways, but it is time to allow our next set of speakers their opportunity at the podium. So first up is Lieutenant General West, who is the Surgeon General of the Army. General West.
All right, good morning. Was everyone awake out there? Let's try it again. Morning. Yeah, no. Well, good morning. It's really a pleasure to be with you here today, and what a great set of topics that we had this morning to start it off. And I really appreciate the great setup from my colleague General Carvalho, Joint Staff Surgeon, and Dr. Geis. Wonderful comments. I always like watching Dr. Geis's presentations are always so very interesting. Appreciate that. And then our discussion on the joint trauma system and surgery, really a lot of food for thought. But today my topic is going to be on the MTFs, our military treatment facilities, as health readiness platforms. And it's really a hard topic to cover in 15 minutes, but I will. And then we'll, of course, have more time to discuss during the platform. And that's the intent of this, is again just to provide some discussion on for the discussion time. Now, before I talk about how our MTFs are readiness platforms, I think it's important to discuss ready for what, because that's really an important way, an important discussion of why we actually are medically ready and why it's necessary. And so I want to start with the concept of the multi-domain battle that you heard General Carvalho talk about briefly. It's a developing concept of how we fight as a unified team, and it's either considered by some an evolution of the air-land battle or a revolution away from air-land battle based upon whatever individual opinion of who's presenting that. And in essence, it's an acknowledgement that, as you've heard here before, in both Dr. Geis's and General Carvalho's discussion, it's an acknowledgement that the military forces of our nation cannot operate within our own individual domains, just parsed out to individual services. Our future fight will be interconnected like we have never seen before. And now you might be asking yourself, so why is the Army Surgeon General discussing multi-domain battle as part of a discussion on a medical ready force? Well, the answer is really quite simple. If I, as a commander and a staff officer, do not understand how we will fight future battles, then I really cannot determine how Army medicine will position in time, space, and purpose to support those future battles. So you hear about the multi-domain battle, but here's the centerpiece. And when you understand that the individual soldier, for the Army's case, or sailor, airman, Marine, Coast Guardsman in the case of my colleague services, is the centerpiece of multi-domain battle. If you don't understand that, and if we understand that, then we also understand that the implications for us all become much clearer. We must do all that we can to ensure the readiness of our individuals to operate at the extreme edge of their physical and their cognitive abilities to ensure that we can dominate in all domains. So that's what we need to focus on, the service member. So we need adaptive, resilient sailors, soldiers, airmen, and Marines, and you heard about the capstone concept of joint operation and some of the attributes that are required, the agility, the adaptability. We need to have that in our service members as well. Again, we need that so we can dominate in all domains. The service member provides the basis of why, especially for us in the military health system or the Joint Health Services enterprise. They establish the why of why we exist. And as a strategic leader, my most important challenge is to maintain that focus on why, even as technologies and delivery systems change, and they are ever changing. So those who have heard my Sergeant Major, Command Sergeant Major Ecker and I talk You'll see this slide a lot, and this is how we view the world. And I tell my staff and individuals that if we don't get this right, taking care of the service member at the point of injury, if we don't get this right, it really does not matter what else we get right, because that's what we're going to be asked to do. That's why we exist. But it's more to that. You can't get this right, and I'll show you the next slide here. The previous slide, as you showed, does not exist in isolation. Yes, it's important that we take care of the service member at point of injury, but we can't get that right if we don't get everything else that leads up into that right. And if you notice on the left side of the slide, what this depicts is everything within or tries to, you can't get everything in it, but it tries to depict all of the different capabilities and the diverse platforms that we have within Army medicine that helps ensure that we get what's on the right side of the slide right. It's our military treatment facilities, it's our veterinary services, it's our research, it's our training and educations, our dental, all of our multiple AOCs that have to be trained and ready to ensure that the individual on the ground is able to take care of that service member. And that shows that there's an inextricable link between our generating force and our operating force. There's really not a line that you can draw between the two sides of that, because again, what's generated at our military treatment facilities, our health readiness platforms, could actually also be part of the operating force at any given time, taking care of our soldiers, sailors, airmen, Marines, whoever comes to us for care at that point of injury. And if any single piece of this system is removed, then the entire system can fail. And this is the real narrative of Army medicine, why we consider ourselves one team with one purpose. So then this leads into the MTF. And of course, as we talked about, the military treatment facilities is one of our centers of gravity for maintaining a force that's medically ready. And also our forces and our medical forces ensuring that they are trained and ready as well. So those are those daily actions that we do in support of our senior commanders to ensure the readiness and health of our forces, again, is captured in our military treatment facilities or executed, to use a word that Dr. Geis mentioned, in our military treatment facilities. And so our MTFs are where we train our teams daily. Our training programs like graduate medical education and research program. Leader development, which is also critical to maintaining a medically ready force. Again, it's not just the clinical skills, it's the leadership skills to be able to make those decisions, to lead those teams, and to have the agility and the adaptability when faced with unknown and uncertain environments, so we can actually continue to do our mission uninterrupted. Also, our MTFs is where our beneficiary population comes to contribute to those case complexities that you heard mentioned, that were extremely important to make sure that our skills, our skilled providers and our support staff have all of the necessary reps to ensure that they are ready to go when asked. And again, our generating side and our operating side are inextricably linked and synergistic, and any break in this chain breaks the entire network. And so to summarize, what I've said here, this is a concept here that I think you heard mentioned. I think it captures what General Carvalho mentioned, captures what Dr. Geis was getting at as far as stovepipes or cylinders or silos of all of us in individual areas. I think, again, the future does not allow for that. The concept that we're showing here is of the Joint Health Services Enterprise, and it encompasses all of the areas that were mentioned in the globally integrated operations and what's required for that. That includes all of our services, the collaboration that's required between the interagencies, that we saw in the response, the U.S. government response to the Ebola crisis. You see that with all of our combatant commands, and the small circles represent the Army components to those combatant commands. You see our NGOs, our international partners, and even our civilian partners are part of this whole enterprise, and is required for us to be successful with globally integrated operations. Because we know we can't do it alone. In the environment that we're going to be in, We're going to be asked to go places, as you heard before, that we may not know. We don't know what capability is required. We don't know what level of superiority, air superiority, freedom of maneuver that we will or will not have. And so we need to be able to rely on our international partners, our civilian partners, our interagency to ensure that the service member on the ground in that previous picture always gets the capabilities that are required to ensure survivability to get him or her back to his or her family. And so, again, this is the multi-layered matrix that you see here. I think that represents all of us and what we do and how we have to work together in the future. And from the component, from the Army component's position, we will not survive in any other environment, one with distinct and significant collaboration. So actually, we'll give you 5 minutes back and we'll look forward to any questions or comments during the panel. So thank you so much for your attention. And now I'll be followed by my colleague, the Navy Surgeon General and the commander of BUMED, Vice Admiral Forrest Faison. Thank you.
Well, good morning. It's my privilege to be up here to chat with you and to share with you some of the things that we as a leadership team with our great staff around the world are doing to keep our force healthy and on the job. You've had a lot of presentations over the last couple days, and I think if I had to categorize our two missions going forward, it would be to preserve skills and competencies and build on the great track record that we've got now in combat survival and keeping that force healthy when in combat and deployed, and at the same time, keeping that force healthy and on the job at a time when we really didn't get a peace dividend out of this last conflict, where operational tempo remains high, where our global commitments remain numerous around the world, and with a force that is rapidly getting smaller and yet is more specialized and more highly educated and trained than any force in our nation's history. Let's see, I push this. There we go. Okay. So as I share with you, our two main goals, our two main jobs is to preserve skills and competencies of our medical team to be able to go forward and save lives in the next conflict. That's a daunting task when you realize over half of that team has been out of high school less than 5 years. And 28% of them will turn over every year, either to go on to a new duty station or to leave military life to get on with their lives in the civilian sector. Contrast that with the Cleveland Clinic, where over half of the patient care team has a baccalaureate degree or higher and has a 2% turnover rate. And all of those young enlisted medical technicians, medics, and corpsmen graduate their initial A-school training without ever touching a live patient. They get their first live clinical experience in our hospitals. So we work very hard to get that workload back in to the hospitals, to give them that clinical experience so the first time they see a really sick patient isn't on the battlefield. At the same time, we use those, as General West said, those hospitals to keep the force healthy and our outreach efforts to keep the force healthy. So who is this force that we're dealing with today? As I share with you, that force is the most highly trained, educated, and specialized force in our nation's history. When I was a lieutenant, there might have been 10 or 15 men or women on a ship that could do a particular job. Because of specialization and complexity of the systems with which they deal, today there might be 2. And if one of those sailors or soldiers or airmen is sick or not a full-up round or is worried about their care their family's getting, that unit's readiness is impacted. Everything we do is critically important to keep them healthy and on the job. So who are they? 3 out of every 4 men and women wearing a uniform today in our armed forces were born after 1986. 3 out of 4. They're millennials. And they and their colleagues in that generation are fundamentally changing healthcare and healthcare delivery. And we must adapt to that or we will become irrelevant. When we were growing up as baby boomers, some would call myself at least a fossil, but when we were growing up as baby boomers, what are the things that we or our parents worried about? We worried about safety and quality. The diplomas on the wall in a doctor's office, those meant things then. Those were the things that we focused on. Is it high quality? Is it safe? Is it good care? The millennials assume all of those things. I'll give you an example of this. How many of you all, would you please raise your hand if in the last 2 weeks you have eaten out at a restaurant? Please raise your hand. Keep your hand up if before you ate the food, you insisted on seeing the sanitation card or understanding where the chef was trained. Exactly. You know that if you're open for business, you can probably eat there, the chef is well trained, and you're probably not going to get food poisoning. That's the way the millennials approach healthcare. They assume that if you're open, that care is going to be good, it's going to be high quality, and you're going to be well trained. That doesn't even enter into their thinking in making their healthcare decisions. And they have a health plan now that gives them more choice than ever before. And as I shared with you, we have to get them to choose us to remain relevant to their health and to provide those patients that those young corpsmen medics and technicians need to preserve their clinical skills and competencies for the next conflict. So what drives healthcare choice today? 3 factors. Far and away, the first and most important is convenience. Come into my ER, the wait time is 5 minutes. There's a major, and you see this across the nation, major enterprises are getting into the healthcare business. Walmart, as an example, is putting clinics in many of their stores over the next 2 years. 90% of the U.S. population, to include our sailors, Marines, soldiers, airmen, and their families, live within 10 miles of a Walmart. And no appointment is required. And if you can't get seen right away, they'll give you a restaurant pager or maybe even a coupon to take money off your shopping. And then they'll page you when the doc is ready to see you. They have integrated healthcare into people's day-to-day lives. So when they can do that, why would you come to our hospitals? And oh, by the way, their health plan allows them to do that now more than ever. As Congress has looked for ways to say thank you to an all-volunteer force, one of the ways they've done that is expand access options for folks. And so our challenge is to get them to choose us in an environment and with a generation that is driven by convenience. It's a big deal to have to call up, navigate the phone tree to make an appointment, drive to the hospital, find a parking spot, which is challenging in some of our facilities, go and sit in the waiting room, see the doc, go to the pharmacy, wait in the pharmacy. It's an all-day evolution. Why would you do that when you just go to Walmart and pick up your dinner on the way home? So that's our challenge, is not making people come to the hospital when they don't need to. The second factor is the experience of care. Valet parking, come have your baby with us and have a meal by Wolfgang Puck. There's a healthcare facility in San Diego that just spent $5 million on waterfalls and feng shui consulting because the experience of care is important today, and that's what they look for. And then the third area that drives millennial healthcare decisions is technology, because they're all digital natives. I'm a digital troglodyte. They grew up with this stuff. We didn't. Interestingly, if you look at the force, 98% of them have a smartphone. And this is an integral part of their life. 85% of them sleep with that smartphone. As of this morning, there are close to 16,000 health-related apps in the iTunes store. None of them went through quality control. All of them are being used by our service members and their families to make important healthcare decisions. That is their primary source of medical information. It's not us. And so we have got to play in that environment or we will become irrelevant to their health care and we will lose visibility on the health of the force. What happens when the unit commander comes to me as the doc and says, "Hey doc, what's going on with Seaman Smith?" And I have to say, "I don't know, sir. He's getting his care at Walmart." Or, "I don't know, sir. He's making healthcare decisions from his smartphone." We have got to play in this arena or we will become irrelevant, because the next question they will ask will be, "Well, doc, why do I need you then?" So this is an operational imperative for us to change how we deliver health care, to get into this area of technology and adapt and using technology to drive health care out of our hospitals. Give you an example of how this plays out. The stethoscope. Many of you use stethoscopes in your day-to-day practice. Stethoscope was invented in 1832. by a Swiss physician. And it's good. It gives you heart sounds. I'm a pediatrician. I used it. It gives you good heart sounds. There's a health plan in San Diego that gives all its doctors smartphones with 2 pads on the back. And you put that smartphone in a patient's chest, and you get those heart sounds. Good stuff. You also get a 12-lead EKG, an echocardiogram, and a Doppler flow study of blood flow through your coronary arteries. And so there's a billboard outside the naval base in San Diego that has a picture of that smartphone and a picture of a pretty ratty, beat-up looking stethoscope. And the tagline on that billboard is your doctor using something from the 1800s to take care of you? So if you're 20 years old, where are you going to get your care? So I went to visit this plan when I was in San Diego. Wednesday afternoon, our clinics are open. Sick bays on ships are open. I walk in, and there are 5 sailors in uniform getting ready to check in. I said, "What are you doing here?" Which is a little unnerving when a 3-star asks that. But to their great credit, this young E3 goes, "Sir, they got these cool phones." This is an operational imperative for us because they will choose alternate sources of care, and the health plan allows them to do that. And we will not have the patients we need to provide that clinical experience that our staff needs to preserve life and our skills and competencies for the next conflict. So what are we doing with this? And I know each of the services have got pilots. We've got a pilot right now to operationalize what we call value-based care. We're doing down in Jacksonville, where we're looking at, hey, if they don't have to come to the hospital, don't make them come to the hospital. 70% of what goes into a primary care clinic doesn't need to see a physician. So why are we making them do that? Think about that for a second. Is it to get the RVU? You know, I think we're beyond that right now. So I went to the CO of Jacksonville and I said, "You are relieved of your business plan. I don't care how many RVUs you get. I want you to enroll as many patients as you can. I want you to recapture as much workload as you can to give your staff that clinical experience they need. And then I'm going to look at how well you take care of them. And I'm going to look at how well you can build loyalty. If they don't need to come into the hospital, provide other ways for them to do that. Virtual care, we're starting corpsman-run clinics in our commissaries. Those corpsmen who save lives on the battlefield need to be doing more than taking vital signs and pushing records in the records room. So we're letting them run clinics in our commissaries to give them that clinical experience that they need and to build that confidence in patient care that they need. We're building loyalty amongst our patient base, and if they do need to come in, making it what we call the frictionless experience. And then once they're there, treat them like you want your loved ones treated. Less than 1% of our nation has ever served in the military. We are a family who have sacrificed to defend freedom. So are our patients. And so treat them like you want your loved ones treated. Leverage mobile technology. It's challenging to get mobile technology approved in DoD. So we're using our community partners technology for now to be able to reach out to them. And then provide rapid feedback loops. Success is built or not at the front desk. But if you're a commander, you frequently don't know when one of your well-meaning receptionists has told somebody, "Our books are full, go to the ER. Our books are full, or our appointments are full, call back tomorrow. Or our books aren't open yet, call back next month." You don't know that. So you've got to have rapid feedback loops. One of the things that we've done is we've adopted what Delta Airlines does at Hartsfield International Airport and use their customer feedback loop that they use at every one of their gates so that immediately they get feedback on if there's a problem. And we're advertising Twitter feeds and things like that at Jacksonville to provide that customer feedback loop. And if a patient gets told one of those 3 things, immediately the CO and the head of patient admin or customer relations gets a tweet and they can surge down to that clinic immediately before that patient leaves, because that patient will on average tell 6 other patients about their bad experience and take care of that clinic and help that clinic get that patient in to be seen that day. And that's all built on a bedrock of standardization. Institute of Medicine talked about the preventable deaths that occur in our nation every year because of variability in healthcare. We are driving out variability in healthcare by standardizing the care that we provide. And success in care ought to be defined by the patient. So at Jacksonville now, if you come in for a chief complaint, the first question you're going to get asked is, what do you consider success to be? For our diabetics, as an example, as a physician, I used to think it's a good hemoglobin A1C, good control of your blood sugars, things like that. Maybe for the patient, it's, I don't want to have foot pain so I can walk my daughter down the aisle at her wedding next year. So we gear our treatment plans now toward success as defined by the patient. And we use clinical practice guidelines to be able to do that. And then we've adopted technologies from the industry, non-medical industry, to help us standardize care and learn, because medicine is an inherently risky business. And so we've used and put in place procedures to be able to learn when things don't go as we would like. One of the things that we're doing in Jacksonville right now is what we call the swarm. In the aluminum industry, aluminum, molten metal, pretty high risk business, Alcoa has 1/10 the safety accidents of anybody else in that industry, because they do this process called the swarm, where when they have an adverse outcome, everybody comes together that was remotely involved in that accident, hot washes it within 12 hours, a notice sent to the CEO. Within 24 hours of that notice sent across all Alcoa plants, and they have 1/10 the accidents of the rest of the molten aluminum industry. Well, we've brought that to our Sentinel events, and we're expanding that now to near misses, so that we do more than just do a root cause analysis, which quite frankly can become a bureaucratic exercise, into actually learning, operationalizing, and rapidly distributing that, so this bedrock of foundation to standardized care is in place. And then on top of that, we build things geared towards this generation and very different expectations that they've had in the past. So what have I told you? We got to change healthcare from the way we've done it before. The hospital-based system of care, and oh, by the way, hospitals got their start in the Middle Ages in the monasteries of Western Europe, where the model was, come to me if you are sick. That's the model we've got today. Come to me when you are sick. That model doesn't work anymore. We have to push healthcare out. We have to make it frictionless when they do need to come in, leverage mobile technologies and other tools to push healthcare and be relevant and influential in the health of our patients, or we will become irrelevant when they choose other alternatives, because their needs and choices and demands for healthcare are very different than what we've seen before. So that's what I would share with you, and kind of where we're going in the future. And I clicked on your slide, Mark, I apologize. So I thank you for your time, and it's my privilege and honor now to introduce Lieutenant General Mark Ediger, a good friend of mine, and the Air Force Surgeon General. Thank you.
Thank you, Admiral Faison. I have a few slides, the primary benefit of which will be that by having slides, you'll be confronted less often with my image on those giant screens off each side. So it's one of those rare examples of PowerPoint as an act of compassion. But, so Admiral Faison's comments on the smartphones and diagnostics was really fascinating, and I don't know about you, but when the day comes when my doctor lays her smartphone on my chest, I'm going to check the brand and the model of that phone before she puts it on there. But I understand there's at least one medical school now in the U.S. that actually has their first-year students buy pocket ultrasounds, and they are not required to buy a stethoscope. Interesting enough. I'm going to share some thoughts and comments with you on leveraging partnerships. And by partnerships, I'm talking about partnerships with healthcare institutions who are outside of the military health system, and primarily as a readiness tool for us. This is something that all three services do today, and I know our experience in the Air Force is that over the past few years we have cultivated and we have become more and more dependent on these partnerships as tools to enhance the readiness of our deployable medical force. I don't see this as something that supplants or replaces our direct care system deployment platforms, our large hospitals, but I see it as a necessary supplement going forward. And so what's driving this? I think the strategic drivers behind this are many of the things that you've heard this week in the presentations. You've heard about the National Academy of Medicine's recommendations on establishing a learning trauma system nationally that merges the private sector with military trauma capabilities. We also know that the combatant commands, the requests that they're submitting for our deployable medical capability are really driving us to take more advanced capability into the operational environment. And by operational environment, I mean pre-hospital, point of injury, field hospital, theater hospital, aeromedical evacuation, CASEVAC. We've also heard this week that there are opportunities, even though we've made great advances in combat casualty care over the last 15 years, there are opportunities to improve the outcomes and to improve our salvage rates by as much as 25%. And so clearly, as we look at how that might occur, as we heard from this morning's presentation from Dr. Stockinger, many of those are by taking better trauma resuscitation techniques farther forward, as close to the point of injury as possible, in many cases at the point of injury, but certainly in the forward resuscitation environment. And we're certainly seeing evidence of that in the deployed mobile surgical teams supporting the combat operations today, that kind of approach can and does save lives. And so these are the strategic drivers that take us forward. And so you heard Dr. Geis reference KSAs, knowledge, skills, and attributes of clinicians. I think this is a very important concept, and the general surgeons have undertaken work that's underway right now to define the KSAs for a military general surgeon very specifically. I think this will help us a great deal because this will give our commanders of our hospitals who have clinicians as part of their staff who are deployable, important readiness skill sets, standards against which to manage the clinical currency of those clinicians so that they're capable to do the things we need to do in support of combat and disaster relief operations. And so in Air Force medicine, while the KSA work is in progress, we've been in the process of really redefining medical readiness for a military medical professional so that we can have some initial standards against which we can manage their practices. And we call this full spectrum readiness. And really what this involves is factoring into our definition of readiness the actual characteristics of the clinical practice of the clinician and the extent to which that clinical practice matches up with what we're going to ask that clinician to do when they deploy. And so we have a three-tiered process we're building right now. Part of this already existed. The clinical currency part is new. And then as the KSAs become available for different clinical specialties, we look forward to factoring those into those. And so we leverage partnerships in order to do this. And so on the clinical currency part that we have in Tier 1, we always look first to what we can recapture and build in the military treatment facility as our primary source of currency for those assigned. But also we leverage local training affiliation agreements with trauma centers primarily in the local community where they can rotate out and do the kinds of cases that we cannot provide them through the demand in our patient population. And then if that doesn't quite meet the standard, then we have established our first regional currency site in Las Vegas, Nevada at a Level 1 trauma center under the University Medical Center where they can go on a temporary duty basis in order to refresh their skills. And then we've got sites that we call our C-STARS platforms, which are really both Level 2 and Level 3 training for us. In some cases, like C-STARS at the University of Cincinnati, it's because they're assigned to a critical care aeromedical transport team. And in other cases, it's like C-STARS Baltimore or St. Louis, where our surgical specialists and our critical care specialists will go because of the skill set we need to maintain for their readiness. These C-STARS platforms are not only opportunities to refresh skills, but also to refresh knowledge on the standards that are part of the joint trauma system. And so as we heard this morning, applying standards and functioning within a learning system is how we improve outcomes. And so that's another key aspect of these platforms, as people go to the partner platforms to refresh skills, they are also getting updates on the clinical practice guidelines and how to work within the joint trauma system, which as we know, has the characteristic in which patients move through en-route care through multiple platforms over the course of their move towards definitive care and recovery. And so this is how we're applying the definitions of full spectrum readiness, and we're working with each of our clinical consultants to establish those. We know in many cases there are not strong bodies of evidence to use to build these standards, but what we've got to do initially is work with our consultants and work with the information available to us from the Joint Trauma Registry to do our best to get it right, and then learn as we go forward by capturing data and continuing to perform research and then adjust as we learn. The platforms involve a broad spectrum of different kinds of scenarios, and of course one is a very important one in which we have other federal systems, primarily the VA, who refer patients to us. This is an excellent source of patients needing more complex care than our population generally demands, and really essential to building up the recapture. As we look at the recapture efforts in our Air Force hospitals, we have succeeded in capturing more specialty care over the last 2 years. The amount of specialty care that we're providing has grown, but it has not necessarily grown in some of the readiness critical specialties. And so the specialties of primary concern for us as we look at our recapture is we have significant shortfalls for our general surgeons in the types of cases they need in order to be ready. And certainly a significant shortfall in terms of the kind of cases the trauma specialists need. And in some cases, particularly at our community-sized hospitals, critical care and emergency medicine. If you look at simple RVU data, it looks like our emergency medicine physicians are in robust, busy practices. But if you look at the type of care they're actually providing in many of our emergency rooms, it falls more into the acute care model, vice the true emergency model that would support what we ask them to do when they deploy. So we think even though the data suggests that they're in robust practices, we know it does not align with what we would classify as full spectrum readiness for those emergency medicine physicians. We also send our providers to federal partner platforms such as the VA to provide cases. We do a good deal of this in Las Vegas from Nellis Air Force Base, our vascular surgeons in particular, and our orthopedic surgeons doing a lot of cases that are more complex at the VA hospital there. We also have partnerships with network hospitals in the TRICARE network where under external resource sharing agreements, that's what URSA stands for, they provide care to our beneficiaries in a hospital setting that perhaps our MTF does not provide. In some cases in those markets, our MTF is purely ambulatory. The training affiliation agreements are really necessary partnerships which can take a variety of forms as you see listed on the slide. A couple of those forms I'll comment on. In many cases, we have staff assigned to an Air Force MTF who rotate periodically through a partner platform, a trauma center, in order to provide care. There is an efficiency cost associated with that, obviously. The time they spent away from our hospital is necessary for their readiness, but it also limits our capacity to provide care in our hospital. And we do it because we recognize by going to the partner platform, they're going to get the kind of cases that we've not been able to capture or pull in. Full-time embedding is something that has grown in quantity in our mission. And we have seen that as those deploy who are in a full-time embedded situation, they do well. They have a high degree of currency on the readiness side. We've also found that by virtue of having full-time embedded staff, that helps make the rotational model work much better for those that rotate through. And then, of course, the bottom bullet on the host nation health system, we have that type of arrangement in the United Kingdom where at Addenbrooke's Medical Center in Cambridge, a very fine medical center, we have worked through the legal process by which our RAF Lakenheath clinicians are able to do cases and provide critical care there. The characteristics we've found of a strong partnership to support our readiness is, first of all, the ability to blend an URSA with a training affiliation agreement. And then strong alignment of the cases we're able to do there with our operational requirements for the particular skill sets we put in there. And it is very important that we work to make sure that the agreement delivers value to both the partner platform as well as the value in terms of readiness for us. It's got to work both ways. The full-time embedded presence of our clinicians definitely makes the partnership work better and makes it a more healthy and productive partnership both ways. And another key characteristic that we insist on is that our people need to be extractable for deployment, and that they need to be able to apply their full scope of practice. The full scope of practice part is particularly important for some of the skill sets that perhaps are not typically found in the partner platform, and this primarily is our enlisted medics. We do have some partner platforms that are now allowing our enlisted to do their full scope of practice in the private sector, and that's going to be very important for readiness going forward. As we look towards the future, we find ourselves asking, particularly after reading some of the recommendations like in the Military Retirement and Compensation Commission modernization report, some people have advocated that we go very heavily in the direction of leveraging partner platforms. I think it's a matter of striking the correct balance. We need our direct care platforms as sources of innovation, as sources of readiness, and as sources of research on operationally relevant health conditions. But within the Air Force, we know that our Air Force has growing mission demands, and so the uniformed personnel we put into our hospitals, that's precious in strength for the U.S. Air Force. And so we have a responsibility to our Secretary and our Chief of Staff to ensure that those people in uniform, that investment in operating a hospital is providing the operational benefit to the Air Force that it needs. And so we know that we've got to assess the possibility that we may need to go over a threshold into the future where, as opposed to putting limited numbers of small teams of trauma or surgical teams into partner platforms, we may find ourselves in the future needing to go to a model where we're putting entire field hospitals in a partner platform, maybe multiple field hospitals such that at any given time one field hospital is available for deployment, and we can assure that partner that we will have a consistent presence day to day from those that are not in the window for deployment. And so that's something that we are assessing as a concept right now, and we think that's something that we will need to take back to our Chief of Staff as they work through their concerns about enough Air Force in strength to meet future military requirements for demands for Air Force combat capabilities. We know going forward that if we can align it with an Air Force MTF, that will be important. We've learned that the ADCON, the support to the people in these platforms is very important. We know that pre- and post-deployment support is essential, and so as we develop that model, that's something we'll definitely need to be mindful of. So that's my overview of leveraging partnerships, and so it is my privilege to introduce my good friend and our valued colleague, Vice Admiral Raquel Bono, the Director of the Defense Health Agency. And she is a trauma surgeon and a Texas Longhorn, I might add. Admiral Bono.
Good morning. So you've heard several themes here. I'll harken back to one of the earlier themes of going from big to small, and I'm the small end of the spectrum, which is why I'm standing here instead of behind there, because otherwise it'll end up looking like the box is talking. You've heard several themes in here, and I think that it's clear that many of us are approaching this with a very different perspective, and I think that's an important piece. Because I think raising the bar is, something that we're all trying to do. But I think an important part about raising the bar is not only seeing things and trying to do things more to get a better outcome. I think sometimes raising the bar actually implies or encourages us to find different solutions, but have different approaches to finding those solutions. And I think we can only have those different solutions and approaches if we're willing to have slightly different conversations. And so as we're looking at raising the bar and the roles that we each respectively play in the military health system, I think there's clearly a lot of value that you've just heard described in each of the services and in health affairs. And I think that our best opportunity here is how we can collectively raise the bar. And so I have three topics or three themes that I'd like to share with you. The first is C2, the second is collective impact, and the third is co-creation. Okay, now y'all are probably sitting there going, is she really gonna go there? Yes, I am. I'm talking about the other C2, the cooperation and collaboration, which I think is an extremely important part about being able to provide collective impact, which then goes to my other area of co-creation. It's been known, and this is something that I've been steadily working on as the director of the Defense Health Agency, and that is our entire focus is on readiness and in our role in supporting the combatant commanders, working as full partners with the services, and at the same time optimizing our operations within our DHA. And I feel that that's foundational to our ability to be able to work together to find those solutions. I was struck by an article in the Stanford Social Innovation Review. And I particularly like this because it was about social innovation and it's about collective impact. And it talks about large-scale change and how you go about getting at that, and the importance of being able to work across multiple sectors in order to effect that large-scale change. And I think that what we've got here in the military health system is an opportunity to embark on that collective impact. The criteria for doing collective impact is it's actually a process. There has to be a common agenda. There has to be shared goals. And I think you can see some of the shared goals that we've talked about here today in terms of our readiness, our currency, our ability to raise the bar. Here's the part that tends to make us a little nervous, and that is measurement. How do we know we're making that progress collectively? And so we need to be able to agree upon shared measurement. You heard Dr. Quartz's presentation and how he described some of the procedures that we're looking at and how we compare to national standards. And I think that's an important part of the conversation that we have to incorporate, because it's not just being able to look at those areas that we're green. We have to be able to widen our aperture to look at those areas where we're amber and red, and then ask ourselves, what do we need to do to get to the green that we'd like to have? There's got to be continuous communication, and I cannot stress this enough, and I think you heard this with Captain Stockinger's presentation about their ability to fast forward to a system of trauma really ended up depending on that communication and that constant feedback loop. And then we have to have mutually reinforcing activities where we're all being able to validate, suggest, and have that conversation. And you've heard many references here. So collective impact, I think, is an extremely important part about what we can bring as an enterprise to raising the bar. I think that there also needs to be a new framework for medical readiness. And I think there's no doubt that what we did in the last 15 years of war was extremely important. And you saw the graphs about our success in our learning together and what worked best in providing that kind of care. But here's a question that I'd like to ask the audience. What would we need to look like? What would we collectively need to look like if we were to design a system of readiness and health that was wholly centered on our patients' needs, values, and interests? And you heard Admiral Faison talk about the first question they asked their patients is about what is their anticipation or what would they like to see as a result of their care. What if we took that a step further and said, what would our healthcare system, our MHS, need to look like if we were trying to be able to be responsive right from the start to the readiness and health needs of our beneficiaries? What would we need to do collectively? And I think you can see here, and you've heard from General Carvalho, that our needs for readiness are evolving as we speak. I heard General Dunford talk about global C2, and now he meant in that C2, command and control. But I think that's a concept that we also need to familiarize ourselves with, because he clearly sees, as do the rest of the chiefs of services, that we are moving to a very disaggregated and multi-domain, multifunctional conflict, ongoing or in the future. And our ability to flex to that is going to require us to think these things differently and allow ourselves to come up with different solution sets. We're talking about modernizing TRICARE, and we put this slide up, and I'll tell you, modernizing TRICARE is not really about just going down to 2 regions, although this is going to be a real driver. And I know that some of my future partners are here in the audience, and I would like to be able to say that part of our ability to modernize TRICARE is not just about some of the things that we see that would make things convenient, although I think that is an extremely important part of that. I think these kind of partnerships in modernizing our TRICARE is being able to, again, have that different conversation about how we can lean forward to take those lessons that are best practices in industry and find ways that we can exploit them that help us promote our own readiness and our own ability to provide that care that we know that our beneficiaries so richly deserve. So I think it's more than just going to 2 regions, but next week I'll be meeting with our new partners as we move out on looking for ways. And again, as you know, we went through this contracting process in collaboration with the services. And as we continue to move forward and understand where those opportunities are with the T2017 contracts, the services are very much involved in helping us design that. This is how we used to do banking in the olden days. Somebody said that looked like me, my mother holding me there. We've moved away from that, and you've heard several comments to this. Our banking industry changed, and healthcare is changing, and we need to be able to adapt to that as well. And I think our opportunity to do that collectively as an enterprise is now greater than ever. Now, this might take you a little extreme in my concept of designing a health system around our patients and asking them what they want, but I think it's an important part to understand what is it that our patients are looking for in their health care. And is it the ability to get back out on the golf course in 10 days after they had a total joint? Or is it being able to have an appointment for your child with a chronic condition without taking them out of school and without having to take time off from work? These are some of the questions we need to ask ourselves in terms of how do we flex to that future state and raise our own bar. One of the pilots that we're doing within the DHA is looking at some of our facilities in the National Capital Region, and we're actually looking at how we're contracting for care in some of our outpatient clinics. And we're taking this value-based approach, and the piece about value-based is it's not just about reimbursement. Value is also what's valuable to our patients, what's valuable to our system, and what's valuable to our readiness. And so as we're looking at how we're doing this contracting with our partners, we're taking this opportunity to go in a different area and see if we can't do this in a way that is more responsive and very different from the way we've done it in the past. In terms of sustaining our currency, you've heard that theme over and over again, and I think that this is an important part. It goes without saying that we're only as good as our ability to learn from what we've done well and poorly. And here you've heard some references to some of the stories that are out there. This is a story that I have a particular personal interest in because I had the opportunity of introducing these 2 heroes from the Boston Marathon bombing. They were victims of the bombing. The male Patrick, who you see warming up there on the the right-hand side of your slide, he had an immediate traumatic amputation of his left leg. His fiancée at the time is standing, the second person from the left on the picture there with the crutches. She had a single amputation and a severely injured right lower extremity injury. And it was through her interaction with our own wounded warriors that helped her make the decision that it was okay for her to have that second amputation and begin working to recovery with 2 prosthetics. This year, Patrick, who you see warming up there, was able to complete the marathon, and his now wife was there waiting to see him at the end of the marathon. But this is an example of how we're being able to take what we learn and help share that with a much larger audience. We talk about partnerships. This was something that Dr. Woodson, now General Woodson, don't know if he's in his uniform out there, helped us with the American College of Surgeons. And so you've probably heard of the Stop the Bleed campaign. So I mentioned just a few minutes ago that we've got to have different conversations in order to help us get to different kinds of solutions. Here's an example of how we can do this in a collective way. Partnering with the American College of Surgeons, not only are we looking at KSAs for surgeons in other surgically related areas, but we're also looking at a campaign of using the things that we use, the tools that we use on the battlefield, and introducing them into the mainstream of the public and letting them be empowered to also respond to mass casualty incidents with the use of the tourniquet. So what you have here is our own joint first aid kit. And when the comments or when the conversation started about what could we do to partner with other agencies and what would we need to do, here is an example of being able to provide this first aid kit to all areas by making sure that we have this on the e-catalog and making that available to all of the areas that need this. We also have the modeling and simulation that we now support across the services through the DHA and with the DHA to help with that training, and then looking at how we can capture all of that into a person's medical record. I can't leave the stage without bringing this up because I think this is an extremely important effort that needs our collective impact, and that is the deployment of our MHS Genesis. It is more than just another IT tool, and I would encourage people that if you haven't had the chance, that this is your opportunity, even in advance of the deployment to your sites, to get involved with the clinical workflows, because that's where we can help drive the standardization and the collective impact that I think is so necessary for us to continue to learn at a very high velocity. And then finally, one of the things that we're doing through the DHA is we're trying to create the bridges between the services and industry that we need to move innovation at a much faster pace to the front lines and to our patients and to our bedside. And so we're partnering with DIUX. I had an opportunity to visit the Austin one. Dr. Geis visited the one up in Boston. And we're trying to look for those ways that we can accelerate our learning and get products to market in a much faster way. So I know that Dr. Geis mentioned our partnership with our international partners, and I think that's an extremely important part, and it's something that we've witnessed here and I've actually experienced in some of my conversations. But the more important piece about this slide is that that's how you can follow me on Twitter and Facebook. I urge you to do that now. There is a contest going on here. But more importantly, what we're doing here, and you heard some of this with Admiral Faison and their use of technology. We're also using technology to make sure that we have that interaction with our beneficiaries, our stakeholders, and our partners. And so what you'll find on both of these sites is extremely interactive. And not only do you hear from me about some of the things that we're working on, but it gives me an opportunity to hear from you about your ideas of where we can make an impact on our collectively, as well as in our discussions for how we can design ourselves, redesign ourselves in creating that system of readiness and health around our patients' values, needs, and interests. Thank you very much.
Okay, so I'm going to invite the Surgeon Generals and the Joint Staff Surgeon up here to join Admiral Bono, and we're going to do the panel. You'll notice that there are 5 chairs, and there's 6 of us, so I'm taking the power position behind the podium. Oh, and the Twitter off is between the 2 of us, and the rule is I'm about to issue a doty on it. Me first. So if you're going to sign up for her, you have to do it mine first. All right. So I'm going to have to do a little bit of the shading of the eyes, but we are willing to take questions. Whether we answer them or not will be up to us. So if you have any questions about things that any one of us said, if you're curious about things that we didn't say, please come up to, is there a micro, I can't see if there are microphones, but there's a microphone right up here in the front, and we will be happy to answer questions for anyone who's brave enough to ask one. All right, here we go. A pop-up guy, okay.
I just wanted to focus on my background as a hospital corpsman for a minute on there must be a way that when you return from a deployment and you're separated from the unit you deployed, whether it's a ship or an Army unit or an Air Force unit, that you can still stay within the culture of the troops you support. Whether every 3 months for a week, they rotate up to that base unit or a like base unit in the region so they learn the culture and they remove the isolation that they feel when they first show up. Just a suggestion.
That's great.
Yeah, that's an excellent point, and it is something that we've been discussing and concerned about. As you look at people who are deployable but embedded in partner platforms full-time, it's important to ensure that we keep that cultural connection. But also it's important to see that we take care of them post-deployment. We've had teams that have gone into places where they've done a lot of trauma resuscitation, and we want to make sure that we support those folks when they come back, and we help them work through anything that may be a consequence of post-traumatic stress, things like that. So that's a key part of the embedded partnership model is how do you see to that connection to make sure that you develop them for future opportunities in our military, and that we also keep them connected to the entity that they're a part of, which is their military service.
Yeah, I really appreciate that comment. You know, one of the things we've learned is, and you know this, when you deploy to combat, that changes your life forever. And there's one person in that unit that's going to see every single casualty, and it's the medical person, whether it's the corpsman, the medic, or the medical technician. And what we have found is that criticality of staying embedded with that culture and that unit is absolutely essential to the healing process. So one of the things that I think we've all looked at is, hey, this artificial of 30 days after deployment, you got to come back to the hospital. No, you need to stay linked in with that. And so we've removed that requirement now for our COs. And I think as we shift more towards understanding the long-term impact and the absolute value of that brotherhood, if you will, or that sisterhood to staying linked together, that's critical to the healing process. So I think we're learning from it. I think we're making progress in that regard. So I appreciate you sharing that.
All right, any other comments from the panelists? All right, next question. Yes, sir.
Hi, I was just wondering, I know in the VA there are issues with pigeonholing personnel. You are this kind of person, you know, the OPM job classifications. And that sometimes, especially nowadays in medicine, gets us into trouble, especially in terms of the crossover between medicine and technology, whether it's informatics or more classical IT, since essentially every medical device nowadays is a computer or controlled by a computer. I'm wondering if that problem exists in the military as well, and if so, how you've overcome it, or have you overcome it?
So
you need clarification?
Yeah, so when you're saying pigeonholing, I mean just identifying singular, you know, types of pathology. So you're diagnosed with one without the multi potential.
No, what I'm talking about is, for example, a PACS administrator in a radiology department. Is it an IT person? Is it a rad tech? The VA has had, just in my experience, you know, significant problems with this kind of issue, where you arguably want someone who's got experience in both domains to be the ideal person, or you may have a small facility where you don't have the need for a full FTE doing this and doing that, and you really want a person who can be the PACS administrator or take care of other medical equipment, but at the same time pitch in when needed to provide medical care. That becomes very difficult in the civilian world. So I was wondering if there's the same problem in the military where, you know, you're assigned to this, or you're this kind of person, or you're paid in this way, and therefore you are only allowed to do this piece of what could be a larger, more integrative or holistic job.
Yes, so from that perspective, I think in the military, and I can, you know, I'm sure with my colleagues, but for the Army, that's one of the things, we cross-train people to do a lot of different things because of the requirement, depending on what environment that they might be in, to be able to do, have multiple, you know, areas of expertise. Now, there are some critical, you know, areas of expertise that require specialized training, and you don't just want to put someone there that doesn't have the specialized training for that, but there are opportunities to do, you know, training, mentorship to ensure that you've got enough to cross-level if required. So we do have opportunities to do that in the Army facilities.
Thank you.
If I could just offer a slightly different perspective on your question. I think that there's such a high degree of specialization, not only in clinical, but in a lot of the technical areas, as you've pointed out. And I think that one of the things, and I think this is a part of collective impact that is a great you know, example, is that what we're finding in the Defense Health Agency is that it is more optimal if we learn how to interface across the agency rather than depend on each area within the agency to be the sole expert on a particular area, whether it's clinical, technical, operational. And so what we've found, and I think that this also speaks to the concept of being able to approach a situation as a team and a collective, is being able to show where those interfaces should occur, encouraging them, and the really fascinating part about this is actually finding the interfaces that you didn't know existed before. And I think that might be a slightly different approach to the question that you asked.
I would just add, too, that we're all victims of our HR system with archaic labels that make us bin people according to that label, and I think that's part of the problem that you're articulating. I think for me, and I think that's the same thing that Admiral Bowen was talking about with the collective impact, it's how you bring people together to solve the problem. So focus on what problem do we need to solve, get the right people in the room to solve the particular problem, regardless of what HR label you've got assigned to them. Yes, sir.
The discussion was very strong about technology, force movement, and so forth. What I don't think I heard was any discussion about the use of patients to provide support. There's a very large movement about patient engagement, the use of patient-family advisory councils. Would you like to comment about your support to help those move forward and make use of them? We're here to help you.
Absolutely. You know, I don't think we mentioned them because we've all got them. You know, we've got patient advisory councils at each of our MTS. We try and include patients where we can on many of our governing committees. The other thing we found is not all patients are the same. There's actually a subset of patients that have got very high needs and also high needs in the community. So we also, as we've rolled out medical homes and our primary care model, we have brought in the community to develop not a care management plan or a case management plan, but a community management plan. And again, as I share with you, it's driven by the patient and what the patient wants and defines as success. So I think we've got that. Could we do more? Absolutely. But like I say, we're not successful if in your mind we're not successful. So I think we've made some great strides in including folks in the ways that we do business. Thanks.
I think another aspect of patient engagement that's important in regard to your point is the personal engagement in terms of their own health. And I think as we've looked at how we need to evolve our medical homes going forward, and as we've looked at the tools that the new electronic health record is going to give us, we see there's strong opportunities to increase the partnership and strengthen the partnership with a patient in terms of managing their own health. And a lot of people think that that's the way healthcare is moving, and where the patient will be kind of the chief operating officer of their own health with with the healthcare team being more in an advisory role, and that certainly manifested by some of the examples Admiral Faison gave in his talk, where people can go out and get their own information now. They can even do a lot of their own diagnostics now. And so I think with MHS Genesis, we're going to have a patient portal that will allow us to implement a lot broader range of tools in terms of allowing patients to see their own information, to interact with the team virtually in between visits. And so I think the opportunities there for patient engagement are going to be strong and important going forward.
If I could also, I appreciate the question, and I think that what I think he might be asking about is how to more actively get the patient as part of the voice in creating that system of health. And when I talked about co-creating, I was implying the co-creation amongst all of us within the MHS, but you're absolutely right, Mr. Hamilton. I think co-creation also means who are the end users, our patients. And I think a really great example of how we've seen how co-creation with our patients can work in a very positive way is the story by Dr. Ed Bentz about Dana-Farber and in their process of building a new facility. And they were down to 2 architectural firms, one of them being a local architectural firm. And one of the firms asked if they could make their final pitch, and when they made their final pitch, they included the patients in that pitch. The board of directors ended up choosing an architectural firm, the firm that made the pitch to the patients, which was not the local architectural firm. The really neat part of that story, though, is that by having the patients be a part of that, the design work and moving forward, what they were able to show is that they made the design of their new facility was very responsive to the interests, the needs, and the values of the patients. But in the process, they also ended up saving $35 million. And so I think that clearly there are starting to emerge some examples of how when we start creating things in full partnership with our patients, and that's why I talked about co-creating a system of readiness and health. What I didn't do very well is talk about how we need to include all elements of those people in the system that need to be a part and accounted for. So I think maybe that might be something you're leaning
Yes.
towards.
And as you know, Fort Belvoir had patients involved from the get-go.
Yes.
Thank you.
Thank you.
All right, next question. This is good.
Good morning. My name is Major Rowan Atun, son of MedCom Headquarters, Health Plan Management. And my question is, over the last three days, I've learned a lot about different initiatives and activities that we need to start doing or think about implementing or co-creating. And I was generating a list over the last couple of days, and the list grew to a point where I just lost count. You know, so I have a full bag of ideas and initiatives. In my mind, I put things in 3 buckets. Either it's value added to our beneficiaries, non-value added but required, we just have to do it, and non-value added at all. So my question is, what are some of those activities or those practices or those things that we're doing today that you guys believe that we should stop doing because they add no value whatsoever from the perspective of our beneficiaries?
Actually, I'd be interested in your list.
That's an interesting question.
Yeah.
So,
No, I'd be interested.
Yeah.
No,
So Dr. Geis.
Yeah.
no, I'd be interested in your list. What do you
Yeah.
think is non-value add?
see there?
I
I'm
would Twitter
serious.
it.
I'd like to start this list with not answering that question.
Well, but I think the point is absolutely right. I mean, what we tend to do as a system is we tend to build it more and more and more and more, and what we ask is everybody to do more with less because we don't get more resourcing for it, and we certainly don't get more people for it. And I think there comes a time when we have to say, what can we do, just as you've put it in the three areas? What is critical that we will have mission failure if we don't do it? So what are the things? And I think that resonated very strongly for me as you saw us talk about readiness. Because the reason we have medical providers in uniform is for a deployment mission. It's not to deliver health care to beneficiaries, it's to deploy. So making sure that we get that right and get that right every single time is essential to what we are as a military health system. And then we have these other things that we do, and then we have to kind of sort through, well, what are those next tier of things that we know we need to do, because we also have a mission to provide beneficiary care, which also doubles down as part of our readiness platform. We know that we need to do research and development, because that's kind of an underpinning of some of where we're going to be in 5 years and 10 years from now. But then pare down the things that are no longer working, and we really think that there's a better way to do something. So I think that's part of what we're going to be sorting through. We certainly have 150 pages of new ways to do things that we will be digesting. But in order to make way for the new stuff, I think we really are going to have to take a serious look at what's that new box look like for us, and what falls outside and what stays inside. So I think your question is spot on, and I appreciate it.
Thank you, ma'am.
And you'll notice how we carefully avoided answering it.
Well, one of the things that I think, just as you mentioned, is really important is, you know, and I think we've all, as commanders or leaders of our units, have asked our individuals, you know, individual subordinates, what can we do to take rocks out of rucksack? That's what I ask my team all the time, is to identify those things, because as leaders, you know, I had an old mentor and leader before that said our job is to take the rocks out of the rucksacks of those that are doing the heavy lifting down at the point of whatever activity or mission that we have. And so I know our team's taking a look. I mean, I think my staff was telling me that there's about 450 op boards, and we're going one by one of what are the things that we've done that we just haven't turned off, that need to be turned off, because we do. There's a lot of things that we're going to be asked to do in the future. And so what can we stop doing? I know when we were looking at the working groups, how many working groups can we stop? But all of them were started for a reason. So things that we do now, hopefully everything that we're doing now has had some reason initially of why it was started. But as was mentioned by Dr. Geis, with the pile-on of all new things, new technologies, new requirements, sometimes with the rush of doing, you know, getting that mission done, what we can stop doing sometimes doesn't get as much focus. And so as we're doing reset, trying to get through with, you know, from the Army's perspective, our Army Medicine Campaign Plan, you know, kept it really simple, 23 pages, and 4 objectives. And if things aren't really mapped to those objectives, which nest into the Joint Concept for Health Services, our Army Leadership Campaign Plan, so to make sure that we have the right capabilities in all domains, in our treatment facilities, in our, you know, for our garrison environment or for our operational environment, how do we relate those back? And so I think it's a constant, you know, struggle, and a constant, you know, we have to be vigilant to make sure that we're taking the rocks out that are no longer as important or needed, and as we put new ones in. Because those rucksacks get pretty heavy.
Yes, they are.
I think the forcing function for a question like this is downsizing or restructuring, and that's what we're facing in the Joint Staff, where we're looking at reorganizing to the tune of a 25% cut that a lot of us are facing. And the direction that we're getting on the Joint Staff is the chairman is not asking us to do more with less, but that we're going to do different with less. So then that forces you to ask what you're doing, what must you do by statute, then what must you do by regulation and guidance, and then what historically has been mission creep. But if I were to categorize the things that we're doing, and no one does things for a stupid reason, there's always a reason, but is it still relevant to do it? And I think if you were to make from my perspective, a broad generalization, is the services can look at things that they're doing and then ask if they're redundant with other services, if there's a way that we can leverage each other for success. In my particular case, I'm looking to leverage the services in DHA to help the chairman, because we're very, very small.
But if I could follow up on your question, I think it is very helpful and valuable when we get this kind of input, because now we're seeing things from your perspective, and then it gives us an opportunity to see, is there something that we inadvertently put in the way, or is there a way that we can help make that not or less of a barrier for you? So I do believe that if you've got those categories, it's worthwhile sharing with your leadership, because that's the only way that we can know whether or not that the process that we're using to evaluate what's value add or not is actually translating as we intended to where you're interfacing with actually doing the heavy lifting, right? So I think it's extremely important that we have that kind of conversation so that we can hear what see what you're seeing and understand whether or not that's a value add to what you're trying to do for the enterprise.
Yes, ma'am.
I will tell you, there is, we can talk about what we should and shouldn't do. There is a must-do for everybody in this room, and that's to educate. As you look at what we've talked about for the last 3 days, you have to ask yourself the question, why do we have a military health system? We're in a very industrialized country with great health care. Why do we have a military health care system? With every passing year, there is an increasing temptation to look at military health care through a civilian lens. We are part of a larger healthcare system that can confuse waterfalls, valet parking, feng shui consulting with quality. And so I need your help to educate. Here's what we bring to the table. Here's why you have a military health system. To get out the door quickly, to ensure that the first casualties in the next conflict, whoever son or daughter that is going to get the best care our nation can offer from the outset to the end of that conflict. And that system ensures that happens. We don't have pretty waterfalls. We don't have feng shui parking or feng shui consulting or valet parking or things like that. But we deliver on a promise to give the best health care our nation can offer. And I'm not sure people always understand that. And that's a real national treasure that, again, as budgets get tight, as things progress on in the national conversation, it becomes very risky to look at a system with a proven track record of combat survival that, as Dr. Stockinger said, has gotten better as we've gone along through a civilian lens. And we have to avoid that. And I need your help to educate people about that. Thanks.
Will do, sir.
All right, I think we've got people standing behind you, although I do kind of like the feng shui parking idea.
Did you like that?
I like that. I like that.
Hello, my name is Daryl Roberts. I'm a registered nurse and a research scientist in healthcare quality with Battelle Memorial Institute. What I wanted to talk to you about was actually what you had just spoken about, Admiral, which is healthcare quality. A great deal of what I do is working in healthcare quality around CMS and around the civilian system, but also when I was working at the American Nurses Association, worked a great deal with getting the National Database of Nursing Quality Indicators to align with VA. To what extent does the military health system and the defense health system align its quality measures with those in the civilian population, and to what extent do we need to learn from what the defense health and the military health organizations do so that when it comes time for a soldier or a sailor to choose between the provision of care that you have near a post or in a post with the doc in the box outside the post, that they can compare apples to apples, the quality of care you're providing on post with the quality of care provided by Doc in the Box or some other provider?
Yeah, no, thanks for that question, and I'll invite my colleagues to pile on here. We use all the same measures that the civilian sector uses. We adhere to the Joint Commission, Sentinel event reporting. Only 15% of U.S. healthcare organizations in the country do that. We are part of that. In fact, I think although we account for less than 3% of healthcare organizations in the country, we make up the majority of the reports because we learn from those. So we do that. We track HEDIS, CLABSI, all the different measures that you would expect to see in a civilian institution. We also track. Because again, we make a commitment to American moms and dads. We're going to provide their son or daughter the best care our nation can offer. And so we look at how the civilian sector does that. We adopt their best practices. We measure the same things that they do.
Yeah, I think you heard comments from Dr. Kortz about our participation in NSQIP, the National Surgical Quality Improvement Program. We also participate in a national perinatal outcomes measures, NPIC. And again, these are all voluntary participation, and many systems in the U.S. do not participate, but we do that. Because we're committed to being able to benchmark our care and our outcomes against the best systems in the U.S. healthcare system.
We also
And I
put our measures on our website, health.mil, so that you can see them. And that's rolled up to the collective military health system. But we also do a fairly intensive once a quarter drill down all together, looking at our quality measures, looking at our quadruple aim. So we have measures for each of readiness, better health, better at lower cost. We focus on the experience of care. We focus on that very intensively once a quarter and really drive to improve performance through that forum.
Right. And then the other part of your question is what can one system learn from the other? And I think that there's really a lot of that, the partnership that General Ediger mentioned. There's exchange of ideas. We've had multiple times when we've seen outside organizations come in. For example, vascular surgeons from the civilian sector early on in the war used to come to launch stool on a voluntary basis. And the exchange, what they would learn from the fresh wounds that we unfortunately were seeing in Afghanistan and Iraq, they were learning and they were bringing best practices from their various practices all throughout the nation. And so you got the cross-section of practices from different areas. They learned from us, and so it was really a very mutually beneficial relationship. And then it also went to the part that Forrest was mentioning earlier about educating, because there's perceptions that maybe there's different standards. We use different standards of quality. And again, like you mentioned, some of the outward appearances may equate to quality, given the visual appearance of some of our aging. Some of our newer facilities look really nice, but some of our aging facilities may not have the same the amenities. But what's happening inside those walls are really high quality. And I think the more we collaborate, the more there's exchange, there's more visibility of what goes on each side, and there's an increase in, I think, appreciation of what both sides can offer, and the great quality that we do provide in our military treatment facilities.
Thank you very much.
All right, ready for the next question.
Good afternoon. Thanks. Great presentations from everyone. Lieutenant Commander Cody Thornton, HHS, ASPR, U.S. Public Health Service, prior Navy, 6 years corpsman. My question revolves around the idea of standardization. We just recently completed a U.S. assessment, the Joint External Evaluation, assessing sort of essentially acute public health and medical capacities to respond to public health and medical emergencies, a framework or requirement under the international health regulations. My question here is, given the footprint that DoD has globally, working with partners on sharing best practices and experience, there's a host of experience that you have domestically, but in doing these activities globally, in what ways does DoD sort of help partners in sharing our experiences and trying to aggregate those standards and best practices into what is now in place globally, helping countries sort of synthesize that information to report it collectively, which we've seen as one of the big issues in reporting on these types of capacities and level of readiness, essentially, for countries to respond to public health and medical emergencies. We do a great job domestically, and in our assessment we saw many different standards and requirements, and we tried to coalesce those domestically and kind of put them in their boxes as to how they align internationally. How does DoD sort of look to aggregate these things with their partners in ways that are standard globally?
So we have partnerships across the globe. PACOM is working very closely with their partner nations, but I have the privilege of representing the U.S. With the NATO alliance and the COMEDs, or the Committee of the Medical Senior Leaders, in that regard. And one of their big focus areas is on standardization, and we do contribute our lessons learned in developing that combined knowledge. So TCCC, for instance, was compared to other options that one may use at the point of injury, and it's not necessarily that the U.S. standard is going to be accepted, but we certainly pose it along with some of the others. I'm very proud of what we do in that regard. That is probably our tightest alliance or allied group that we have working. And I'd have to get back to you on how tightly we're doing that in other AORs, whether SOUTHCOM, PACOM, et cetera.
So in speaking for the OSD side of the house here, we do that in the PEPFAR program. It's a strong partnership, as you well know, and a lot of collaboration. I think we've really had over the past several years a real focus on let's make sure we get it right. Let's capture what we need to do. Let's compare ourselves. Let's set up goals and really get the partner nations to participate at a higher level. And I think it's been very successful. Today is International AIDS Day, and or World AIDS Day, and so I think there's going to be some information disseminated to everyone about how the PEPFAR program has been able to do that. So that's one example of where we've done it. I don't think it's quite as formalized in some of the other areas that where we have these engagements, but certainly capturing what we do and what we do well is something that we value greatly, as General Caraballo said.
Right, and a lot in kind of an offshoot of building partner capacity with our various partner nations is. It's not a specific standardization, but we've seen where there are sharing of ideas, sharing of how we would respond to certain situations or certain disaster relief or things like that. We've seen progress there where now, where before there was a call for maybe the U.S. or other forces to provide capability, that capability was actually built within the nation, and that actually reduced the need. And so it built capacity with our partners and reduced the need to, send capabilities from, divert it from other areas. And, for us, so that was kind of a win-win in other areas. So there are areas of that all throughout the globe in different areas of doing the capacity building. But the standardization piece is one that I think everyone's trying to work on. And we saw that again with the U.S. government response to Ebola. I think a lot of goodness came out of that with the USAID-led effort of really showing how interagency can work together so there's just the standardization among our agencies, I think, really took a very big leap forward during the response to, the U.S. government response to Ebola.
Thank you.
Sure.
All right, next question. The line's getting longer, too. That's good.
Art Kellerman, I'm Dean of your medical school. And so my question is really speaking as an individual, not on behalf of my institution for reasons that may appear obvious in a moment. As I look back over the presentations this morning, they really were remarkable, not just yours, but the panel that preceded you. And the collective story they tell is incredible. Coming into this world 3 years ago out of civilian academic medicine, I can tell you nothing in American medicine in the last 15 years remotely compares with what the military health system accomplished downrange in Iraq and Afghanistan, in the air back to the United States, and in the U.S. in the evolution of combat casualty care. It is one of the great success stories in the history of American medicine. And you've heard this morning some of the qualities that led to that: requirements-driven research, data-driven decision-making, joint trauma system, absolute unity of effort, reliance on telehealth, use of all the personnel on the team, task shifting, a number of qualities and characteristics that achieve that. What I hear as a dean when I talk to my faculty, my students, your colleagues, is that they sometimes have a sense that there is the MHS downrange and then the MHS at home. But if we take that old American adage of practice what we play and emulate those qualities in the MHS in CONUS, might that not only help prepare each individual to be better prepared and each team to be better prepared for the next conflict, but the entire system? Don Berwick, who founded the Institute for Healthcare Improvement, wrote an editorial in JAMA a few months back, and I love one of his quotes. He said that the military health system invented or was practicing the principles of a learning healthcare system before the Institute of Medicine defined it. If we, you, can do that downrange, can we not do that here at home by embracing those very same qualities, those very same techniques, that very same unity of effort in what we do in our MTFs, in our training platforms, and with our individual personnel?
No, I really love that because, and that's the whole concept of the Joint Health Services Enterprise, where it has all of the elements. And if you saw USU is up there, did you see your emblem was up there? Because it's all part of the enterprise, and that's what I really try to drive home. And it was, You know, there's this sense of trying to put a dividing line, like I mentioned, between garrison care and operational care. And a lot of times, you know, there's a perception that when the term MHS is used, people automatically think just garrison care, MTF, and that's where we can compare ourselves side by side, you know, with our civilian counterparts. As Forrest mentioned before, sometimes people go to that, and then they say, well, yeah, you guys got the operational piece. You know, we know you got that. But they don't realize, well, that is this, like I tried to capture. It is an inextricably linked continuum of care. So when we talk about the whole Joint Health Services enterprise, it's not just one segment, and you can't, I don't think, draw a line and say this is where this starts and this is where the next element of it starts. And so as much as we can really bring home that concept, because there's a lot to be learned from the whole, you know, the whole way that we do things, like you mentioned, point of injury, all the way back to definitive care and beyond. And that's when Joe mentioned, you know, as the Joint Staff Surgeon, when he identified what the capabilities are that's going to be required, those 16, it is the entire, you know, universe of what we do pretty much, or tries to capture in our Joint Health Services enterprise. And I think we all have to be champions of that, saying, hey, it's one system, one continual system. It's not, you know, this one here and then this one downrange. That's great, thanks.
Yeah. Sir, if it's a train like you fight, the issues that I see from my seat is not every skill that is practiced in the brick and mortar is actually needed downrange. And I think the services are going to have to come to grips with how do you justify that person being in uniform. As an example, we have never called for radiation oncologists to be deployed. So what is the reason to have that person in uniform? And there is going to be a reason. It just has to be spelled out, other than an employable factor. The other thing is our downsizing is going to force us to, I believe the service is going to force the service staff to think that they cannot come to a joint fight as a separate service, show up and say that that's their contribution to the joint force. I think the idea of working in an integrated fashion interchangeably, which is the charged word, and I know people will be excited for me to retire thinking that word will go away, but what they don't understand is I'm planting this seed with the young guys so that as they become senior, this idea that when we're, as Dr. Guy said, when we're in scrubs and mask and cap, you can't tell what service we're in. That's where we have to be. In the enlisted world, we start at METC. For some of us in medical school, we start at USAF. The DHA hospitals run the way they are. Depending on what NDAA 17 says, every hospital might be a DHA hospital. That will get us to the point where we're all working at the same level. KSAs are going to be critical to this, so that a surgeon is a surgeon is a surgeon no matter what service, and now you train to the platform, whether it's with the Marines, on board a ship, on the ground, in the air. And so each service, I believe, will have primacy, air, land, and sea, but they can be augmented reliably so by a sister service if they're short for some reason. I think that's where we're going to need to think about going, but that's going to be the services call.
Thank you.
All right, I think we're going to have time for maybe 2 more questions. We have a hard stop at noon, I'm told. Like, we really have to be out of this room. So, next question.
Good morning, Kathleen Madsen, a health services researcher at USAF, so your medical school, again, thank you. I have been looking into some of these issues that many of today's discussions have addressed, and if I can ask a question that ties them all together. For instance, the Pronovost checklist that was referred to in this morning's session, the telehealth that was referred to in this panel discussion, the SWARM means of addressing industrial accidents and near misses from Alcoa. All of these things require major culture changes in the way these organizations do business. Even something as simple as the Pronovost checklist, if you read the book about how that came to be, there was a great culture divide between the doctors and the nurses at Johns Hopkins, and in order to push even a simple 5-point checklist forward to address one means of preventing infection in one hospital required a whole cultural system to be put into place whereby those lower in the chain, so to speak, had the authority to call out those who might be above them for not following the checklist. This is just one example. There are many more. Of course, in telehealth, there's always the issue of two different hospitals, two different ways of doing things, two different cultures. In industry, there's always the issue of we do it this way here, we do it that way there. What is the plan for addressing the cultural shifts that will allow these innovations to reach their full efficacy in the military health system?
You're right. This is cultural change. I mean, standardization, we're all artistes. How we practice medicine depends on where we were trained. And to then move to best practices and clinical guidelines, which some would call cookbooks, again, resistance to change, is a major cultural change. And so we're not going to be immune from that. And we're going to need to work through that. And that's got to be driven from the deck plate. Cultural change isn't successful if it's only driven from the top. We all know that. But we do have something in our quiver, which is an incredible tool, which at least we found helpful. Why'd you go into healthcare? You know, hopefully you went into healthcare to take care of people and make a difference in their lives. And if you can portray something as, this is going to help that, you know what, people buy into that. We're down in Jacksonville, all the things that I talked about that we were doing down there, that's a huge cultural change. But you know, if you sit there and say, hey, you know what, that patient that comes into your room that needs your help, that person that's in crisis, is going to be better if you do this. You know, people roger up to that. It's an enormous tool that I don't know that we tap into all that frequently or all that well, to say, go back to and look at yourself in the eye and say, why did you go into healthcare in the first place? When you were deciding what you want to do with your life, why did you choose healthcare? And get back to that and frame it along those lines. The take seems to be better. That seems to make things easier.
If I could just follow that, I alluded to this in the collective impact, and I think the thing about collective impact is how do you make large-scale change happen? And it's got to be across a very broad spectrum. And the first part of that is agreeing on what it is that you're trying to change. The second part of that is being able to agree upon the measurements that you're going to use that mark your progress to that. And so there's actually a structured process to making change happen. And I would say that that's also, that change there, that change process is also what helps make that cultural shift occur. So I think that collectively, that's something that we have to, if we're looking at readiness in particular, how do we want to define that? What is our shared definition of what readiness looks like? And then how can we across the board agree that this is how we're going to measure it and this is how we're going to validate that those measurements and those drivers are actually getting us to where we say we collectively want to go. So I think that it's definitely aspirational, and I think that this is an important part of what we're trying to do. But like with any change, there is a process to that, and I think we need to employ that, you know, across our enterprise.
I think as you look at how do we focus our new commitment to quality, safe care and control cost at the same time, I think there's some very fine examples out there in the healthcare industry. And so recently we heard a presentation from Dr. Brent James at Intermountain Health, and they've published data, and that's one example of a system that's done remarkable work through employment of standards and maintaining standards and upgrading and adjusting standards and having a system and a process to do that, to where they have both improved outcomes and improved health in their population while bending the cost curve downward. And so that's not something you do just with a new set of metrics or dashboards and a new set of policies. That, as you said, is a cultural change. And so the way you really get at that is you actually develop your people to know the principles and the standards by which you manage and you lead. And so you'll see that incorporated within high reliability. You know, the work we're doing to apply those principles, you see it in continuous process improvement. But you've got to have a system that ties all that together, and then you develop your people so that as they move up through their levels of responsibility, they actually understand how to lead in a culture that's focused on the experience of care for the patient, focused on the outcomes for the patient and is highly vigilant for risk and is committed to mitigating risk wherever it exists. And I think the way you really drive a culture of change is you lead it in a way that develops people with deliberate educational events as they move forward.
And I would just add, kind of to double tap two things. One, Rocky, you said it's aspirational, and then what you said, getting back to the basics of what do we go into healthcare for? Because just look at the challenge. Just think of the question that's being asked about cultural change. If you go into any bookstore, for our younger folks, books are the things with pages, you know. But look at the organizational change section and count how many organizational change, processes, books, theories are. And there have been, in my 30+ years, I cannot tell you how many different organizational change processes we've gone through. So just, I would also say that to realize the challenges, if we go to standardization, there's a pressure out there because there are a lot of great ideas and everyone has a great new way. Every organization comes up with a different way. And then there's a push to standardize. And so we are asked to standardize in a culture and an environment and a society where standardization is not necessarily the key. I mean, there are vendors that have multiple different ways of doing things, electronic health records, PAC systems. And so I think that as we go through standardization, just realize it's an aspirational thing, because how do you really get there when there are so many, because there's not one right way of doing it. When we talk about our healthcare partners in our civilian sector, there's not one. If you go to each one, you can glean from all. And so it's really, in an environment like that, cultural change is really very complex and very difficult, because there are so many, because there is no one right method, book, theory of organizational change. And that's also the pressure that I think we're under as a huge organization like the Joint Health Services Enterprise. Can you imagine trying to get everybody on one different path? But it's aspirational and getting back to the basics of what Forrest mentioned.
Well, we have been given the hook by Admiral Cowan. So we are at the end of our time. The clock has literally run out in front of me, and we've gone over just a bit. So we will say goodbye to you all for now. I am sure that if you catch one of the Surgeon Generals out in the hallway, they'll be happy to answer whatever other questions you might have, or you can just tweet them all to Admiral Bono. Thanks, everybody.
That concludes our plenary session for this morning. I would only comment that I've never heard so much useful information downloaded so fast. I want to thank all the panelists and all the speakers, and Dr. Geis in particular, for putting this together. Enjoy yourselves this afternoon at the breakout sessions, and we'll see you back here tomorrow morning.
Ladies and gentlemen, if you could kindly exit this space, we do need to prep the room for this evening's awards banquet. Thank you.